Good morning. I hope you all slept well and are ready for a new day of exchanging ideas and changing the future. I want to thank the organizers for inviting me to give this kickoff presentation. I am nervous and excited. I think this is this, but oh. I have what some still call a conflict of interest. I am a patient advocate for people with lung diseases, especially asthma. I work in all sorts of settings on improving our care. I also work on getting the experience of patients validated and accepted by others. I am one of the UPATI Fellows, a group of around 100 patient advocates throughout Europe who do the same in their own disease area. Together, we want to get patients heard in research, medicine development, HTA, Medical Ethics Board, have legislation that requires patients to be involved in all areas of development and health. So yes, I have interests, but are they conflicts? Let's go to the next one. Can I do that? How do I get to the next slide? Yes. I will try to take you on a journey through the effects of engagement. I will use a few examples from the area of lung diseases, my area of expertise. These examples are not exceptions. They stand for what is happening in many disease areas where engagement can be improved in the future. What is engagement? By engaging with others, you expand your context. You share your context with others. You add other realities to your own reality. You go into meaningful interaction with others. In my presentation, this meaningful interaction will be about engaging with patients, adding the real-life knowledge of patients to the knowledge of the researchers, the pharmaceutical companies, regulators, HTA, policymakers. And it is not just adding this real-life context. It is a path of creating mutual understanding and valuing the differences and working towards cooperation and co-creation. Patient engagement has developed tremendously in the past decades. In more and more situations, patients have become part and have a say in their own care. This has led to involvement in patients in the care system. By example, many countries have a patient board in hospitals, and it is a legal requirement. Patients have become involved in guideline development. The European Medicine Agency is a star in developing patient involvement and taking it to the next level. But patient advocates want more. Why? Because we see a lot of ways of improving patients' lives. And in our minds, the way forward is to engage with patients even more, not just to improve our lives, but to improve where money and energy is spent. The next step for patient engagement is where the decisions are made, where the knowledge is developed. That is the basis of the decisions, where the money is spent, how the information is gathered is valued, how the information, knowledge is disseminated and given value to make complex decisions like reimbursement decisions. We live, let me see, where am I? I'm here. We live in difficult and exciting times. The technology has made it possible to enter into new areas of research. These new development shifts the way we think about disease, care, research, etc. The lives of patients can be transformed. New questions can be answered. New questions can be asked by all of us. What an incredible time to improve engagement between us all. I will give some examples. They are not about the state of the art, but about real life. Asthma patients use inhalers to get their medication directly into their lungs. The way the inhaler works is by using the airflow of inhaled air to bring the medication in the lungs. However, The volume and the power of the airflow of these inhalations can be severely compromised in asthma patients. The solution was found in what is called spacers. An air chamber was used. The medication is mixed with air so that the patient can inhale this medication-rich air with less effort. Sufficient medication gets into the lungs, leading to a better asthma control, less hospitalization, i.e. cost, and I mean not just monetary cost, but all costs reduction. A clever idea. The first spacer was an enormous, unwieldy plastic device. This spacer was developed without patients, and patients did not use this spacer. This was seen as the patient's fault. Talking to the patients created a different reality. The spacer was developed with the idea that asthma patients never leave their house and never take their medication with them, which is far from what happens in real life. The spacer was not built for transport. The plastic it was made of was really very fragile. It cracked and broke easily. The reimbursement decision was that you could only get one spacer reimbursed per year. So after a month, your spacer wasn't working anymore. It was not that patients were not adherent, it was made very difficult to be adherent. The costs to patients, the health system, researchers, and the pharma company were high. A new spacer was developed that is easier to transport, easier to use, and sturdier. And now, pharmaceutical industry develops inhalers that can only be used with the spacer. I talked about inhalers in my previous examples. Many asthma patients use more than one type of inhaler, a basic inhaler and a rescue medication when you notice that you are getting breathless and need more medication to avoid an exacerbation. The medication helps to get the asthma attack under control. Not getting an exacerbation under control can lead to hospitalization or even death. High costs to society and patients. This is my rescue medication. It looks okay. This is the medication I carry with me every day and only use when needed. There is, however, for me no way to know when my rescue inhaler is empty. There is no indication of the amount of inhalation still available. This has led to many people carrying empty inhalers with them, with the consequences we have talked about before. Fortunately, new inhalers are becoming available. Though small, you can now see how many inhalations are still available. You can order your medication on time. You can replace your empty inhaler. A very simple, very effective improvement. However, it still depends on the pharmaceutical company whether their inhaler has this function. Developing the products together with patients might have avoided these problems, decreasing costs dramatically to everyone. Setting research agendas together with patients is the new trend. It leads to research that has greater impact on the care and quality of life for patients. The research looks at more unmet needs, at problem patients have in daily life where there is no solution. One of these areas is fatigue, another one is pain. Many patients with chronic disease suffer from fatigue. This is one of the most underdiagnosed, not talked about aspects of daily life. The Dutch Lung Foundation started involving patients in setting research agendas in 2004. The number one on the patient's agenda was research on fatigue. In 2009, again, patient's number one was fatigue. In 2016, again, fatigue was number one. Nothing has been done in the past 13 years to in research on fatigue. We had great conversations and exchange of ideas during the meetings when the research agendas were developed. However, it had little or no influence on what researchers, scientists, subsidy providers, research organizations, pharmaceutical companies, and policymakers prioritized. But we do not give up. In the past year, I was a member of a group of people who worked on a Dutch and a European research agenda on asthma. Wherever possible, I will ask, why don't we prioritize the research we plan based on the research agendas? It does not have to be fatigue, but at least let's talk about why not. As Nicola already talked about, the HIV/AIDS community is one of the earliest communities that changed patient involvement. There was no treatment. There was little interest in developing treatments. EATG started in 1992 and was with its main goal to simultaneously develop not only antiretroviral therapies, but also treatment for opportunistic infections and other AIDS-related conditions. EATG is involved in scientific research, policy and advocacy, and capacity building. They are a force to be reckoned with. Patients were on the forefront in this disease being taken seriously. Having companies invest in developing medicines, continuous improvement of care and visibility of all groups suffering from HIV/AIDS. The European Medicine Agency has a special HIV/AIDS working group that was key to new developments and new ways of looking at the role of patients, new ways of using the patient reality as a driving force. EATG fought hard, met a lot of resistance, but care improved, medication was developed, engagement created a multitude of benefits. Health technology assessment is an area where patient engagement is highly discussed. There are many, including IMI project on patient involvement in HTA. But in most countries and most health systems, the discussion is still at the level, should patients be involved? They should be involved. They should only be involved in the ethics part of HTA. Many opinions, limited experience and practice. HTA is one of the few economic policy analysis methods where stakeholders like patients are not involved. HTA is the basis of decisions on health interventions. But is the present practice good enough to base these decisions on? Do these decisions not require broader considerations? Does the way we do HTA not lead to poor validity and credibility? Does that not lead to suboptimal allocation of resources? Hazel Squire asked these questions. She started research on what was being done and looked at the ways to improve the HTA system. She involved patients and other stakeholders to identify the key impacts of the intervention. Hazel then put this new model into practice in a case study assessing the cost effectiveness of screening and preventing for type 2 diabetes. Talking to stakeholders changed the framework and the model used. The perspective of patients completely changed the way the researchers saw their own model and how to judge the validity. Karen Facey and colleagues published a book on patient involvement in HTA. They advocate involving patients in HTA. It will improve credibility, salience, validity, relevance, fairness, equity and legitimacy. And by involving patients, we will also build capacity for patients and HTA organizations to work together. The profits, positives that will come out of engagement are just starting. There have been some big positive results in rare diseases and some big problems, like a Dutch patient organization taking the Dutch government to court on a reimbursement treatment decision challenging the HTA analysis. In Italy, patients suffering from multiple sclerosis are not getting the community care they need. They have been diagnosed at the hospital, but now patients and their care have been monitored and has to be monitored and provided by the local health center in the area where the patients live. This is not happening. The San Camillo Forlanini Hospital tackled the issue from a different angle. Clinicians and patient experts working together and identifying the problem and finding solutions together. Paula Kruger, one of my fellow Upati fellows, is involved in the project. Why are multiple sclerosis patients not getting the care they need? What is the main issue preventing this? It turned out the problem is quite simple. It is an issue of communication between the hospital and the organization that allocates resources in the region. By developing a software application that facilitates communication between the hospital and the regional organizations, patients with multiple sclerosis can now receive the care they need. A simple solution which will create a win-win situation. Patient engagement can lead to solutions because the questions and information are changed. The patient adds a different context. The context of living with a disease and knowing what works in daily life. It is a good starting point to analyze what can be improved. Adding different contextual information to everyone's own perspective can only improve the future further. But this is not an easy road. Everyone has to be willing to listen. It requires that we value each other's perspectives equally. We all bring equally important but different knowledge and information and perspective to the table. It is a paradigm shift that is happening at different speeds, at different areas in the whole system of healthcare. It is a paradigm shift that will influence every stakeholder. I hope and think it is an unstoppable process. This is the time to start making the changes at all levels. It won't happen overnight. It requires effort from everyone. It requires training for everyone. How does a researcher, a scientist, talk to a policymaker or a patient? How do you involve patients in medicine development? The first step is willingness to get involved, to get engaged. The process will not happen if we do not want to commit resources. Working with new partners with different backgrounds is not an easy process. Your basic premises will be challenged. They might ask questions you have no answer for, but that does not mean they are not worth answering. It is not who is right or who is wrong, but about creating a space where all are heard and valued equally. This requires effort and investment from all. The one question I have is, where in the process are patients engaged? Who is responsible for engaging patients? Who checks what is being done? By example, in the pharma industry, patients are often invited by the communication marketing department. Why? Is this where you want patients to be involved? Keeping legal restrictions in mind, there are other ways in involving patients in medical development. Why not learn from each other's practice? There is no limited exchange and limited learning from experience of others. There is now limited exchange and limited learning from the experience of others. How about incremental learning? The question I leave with you is, what happens if we don't engage? Thank you for your attention. We'll have time for questions. Let's do it and not just wish it.